Welcome to Pediatric Case Review, Musculoskeletal Series. Today we present a comprehensive board-style case-based review of juvenile psoriatic arthritis. This condition is an important and often underdiagnosed form of juvenile idiopathic arthritis with unique clinical features. We will cover 14 carefully designed clinical cases addressing clinical presentation, examination findings, pathophysiology, classification criteria, imaging, investigations, treatment, complications, and prognosis. Let us begin. Case 1. A 4-year-old girl presents with a 6-week history of right knee swelling and stiffness. Her mother noticed she has been limping in the morning. On examination, the right knee is swollen and warm. The mother also reports some scaly patches behind the child's ears for the past month. What is the most likely diagnosis? Option A. Septic arthritis. Option B. Juvenile psoriatic arthritis. Option C. Oligoarticular juvenile idiopathic arthritis without psoriasis features. Option D. Rheumatoid arthritis. The correct answer is Option B. Juvenile psoriatic arthritis. This is a classic presentation in a young child featuring oligoarticular onset with single knee involvement, subtle psoriatic skin findings behind the ears, and a bimodal age distribution with a peak in preschool-aged females. The presence of psoriasis, even minor, in a child with chronic arthritis strongly suggests this diagnosis. An important clinical pearl is that in children, arthritis often precedes psoriasis by months to years. This is why thorough skin examination is crucial. Look for dactylitis and nail pitting as distinguishing hand signs. Case 2. A 5-year-old boy with known psoriasis presents with characteristic sausage digit swelling of his left third finger. The swelling extends beyond joint margins. There is tenderness along the finger, but no significant warmth or erythema. Radiograph shows soft tissue swelling with no erosions. Which finding is most characteristic of this condition? Option A. Synovitis of the proximal interphalangeal joint only. Option B. Tenosynovitis with flexor tendon involvement. Option C. Enthesitis at multiple tendon insertions. Option D. Septic arthritis with periosteal reaction. The correct answer is Option C. Enthesitis at multiple tendon insertions. Dactylitis, or sausage digit, is a hallmark symptom of juvenile psoriatic arthritis, affecting 20 to 40% of patients. Contrary to previous understanding, the pathology is not just joint inflammation or synovitis. Imaging confirms that dactylitis is predominantly driven by enthesitis at multiple tendon insertions across the digital rays, such as flexor pulleys. Imaging reveals enhanced signal at digital entheses and bone marrow edema. The multifaceted inflammation including enthesitis, tenosynovitis, synovitis, and new subperiosteal bone formation results in the sausage digit appearance. This finding has high specificity of 95% for this condition. Case 3. A 7-year-old girl with chronic knee and ankle arthritis is examined. Examination findings include multiple fingernail pits and toenail onycholysis, which means nail separation. Her mother has psoriasis, but there are no skin plaques on the child herself. What is the clinical significance of these nail findings? Option A. They indicate fungal infection requiring antifungal therapy. Option B. They are nonspecific findings unrelated to her arthritis. Option C. They are highly suggestive of psoriatic diathesis. Option D. They are diagnostic of coexisting atopic dermatitis. The correct answer is Option C. They are highly suggestive of psoriatic diathesis even without skin plaques. Onychopathy occurs in more than 50% of juvenile psoriatic arthritis patients compared to 30% in general childhood psoriasis. Recognizing features like nail pitting and onycholysis is vital. These nail changes are recognized International League of Associations for Rheumatology classification criteria when skin psoriasis is not present. They may reflect underlying enthesitis at the distal extensor tendon insertion. Their presence, especially with a first-degree family history, strongly supports the diagnosis even without visible skin plaques. Case 4. 2 siblings are presented with distinct clinical features. The boy is 12 years old and has heel pain, back stiffness, a swollen right knee, and is positive for the human leukocyte antigen B27 marker. He also has scalp psoriasis. His sister is 4 years old with bilateral knee and small hand joint arthritis and is antinuclear antibody positive. Which statement best describes these presentations? Option A. Both children have the same disease with different severity. Option B. The boy has enthesitis-related arthritis while the girl has juvenile psoriatic arthritis. Option C. They represent 2 distinct phenotypic subgroups of juvenile psoriatic arthritis. Option D. The girl has rheumatoid arthritis and the boy has ankylosing spondylitis. The correct answer is Option C. They represent two distinct phenotypic subgroups of juvenile psoriatic arthritis. The younger phenotype, typically under 5 to 6 years, is predominantly female, anti-nuclear antibody positive, with early onset oligoarticular pattern resembling juvenile idiopathic arthritis, and driven by autoimmune pathophysiology. The older phenotype, seen in adolescence, is enthesitis related with axial involvement, resembling adult psoriatic arthritis, and driven by autoinflammatory pathophysiology. Shared features between both groups include dactylitis and wrist and small joint involvement. Understanding these two phenotypes is essential for appropriate management. Case 5. A 6-year-old girl presents with arthritis affecting her left knee and right ankle. She has a first-degree relative with psoriasis. On examination, she has dactylitis of her right second toe and nail pitting. Laboratory tests show negative rheumatoid factor and negative human leukocyte antigen B27. According to International League of Associations for Rheumatology classification criteria, what is required to classify this as juvenile psoriatic arthritis? Option A, presence of confirmed psoriasis in the patient. Option B, either psoriasis or 2 of 3 features, which are dactylitis, nail changes, or first-degree relative with psoriasis. Option C, presence of enthesitis on examination. Option D, positive anti-nuclear antibody titer. The correct answer is option B. The International League of Associations for Rheumatology criteria require arthritis plus either confirmed psoriasis or 2 of 3 supporting features, dactylitis, nail changes such as pitting or onycholysis, or psoriasis in a first-degree relative. This patient fulfilled the criteria with dactylitis and nail pitting, even without confirmed psoriasis. Important exclusion criteria include human leukocyte antigen B27 positivity in males over 6 years of age and rheumatoid factor positivity. These exclusions help differentiate juvenile psoriatic arthritis from enthesitis-related arthritis and rheumatoid factor-positive polyarthritis. Case 6. A researcher is studying the immunological mechanisms of juvenile psoriatic arthritis. Biopsy samples show prominent T-cell infiltration, mast cell populations, and myxoid expansion of the extracellular matrix at enthesial sites. Which cytokine pathway is most implicated in the pathogenesis of this disease? Option A, interleukin-1 pathway. Option B, interleukin-6 pathway. Option C, interleukin-23 and interleukin-17 pathway. Option D, tumor necrosis factor alpha pathway only. The correct answer is option C, the interleukin-23 and interleukin-17 pathway. This pathway is the central axis in psoriatic arthritis pathogenesis. The primary site of inflammation is the enthesis, which is the tendon or ligament insertion point. Interleukin-23 drives differentiation of T helper 17 cells, which produce interleukin-17. Interleukin-17 then drives both skin inflammation causing psoriasis and joint inflammation causing arthritis and enthesitis. Histologically, T-cell-rich infiltrates, mast cells, and myxoid matrix expansion are seen at entheses. This pathway is therapeutically targeted by ustekinumab, an interleukin-23 inhibitor, and secukinumab, an interleukin-17 inhibitor. Case 7. A 10-year-old boy with suspected juvenile psoriatic arthritis undergoes hand magnetic resonance imaging. The imaging shows extensive bone marrow edema extending to the diaphysis, flexor tendon enthesitis, extracapsular inflammation, and minimal synovial thickening. Which statement about magnetic resonance imaging in juvenile psoriatic arthritis is correct? Option A. Magnetic resonance imaging findings are identical to juvenile rheumatoid arthritis. Option B. Bone marrow edema is more extensive and extends beyond subchondral bone compared to juvenile rheumatoid arthritis. Option C. Synovitis is the most specific finding for differentiating juvenile psoriatic arthritis from other arthritis. Option D. Magnetic resonance imaging has limited value in early diagnosis. The correct answer is option B. Bone marrow edema in juvenile psoriatic arthritis is more extensive and extends beyond the subchondral bone into the diaphysis, which is a key distinguishing feature from juvenile rheumatoid arthritis where edema is limited to the subchondral region only. Enthesitis and extracapsular inflammation are common findings. Diffuse soft tissue involvement is also seen. Magnetic resonance imaging detects early inflammatory changes before clinical or radiographic evidence appears. Whole-body magnetic resonance imaging has been shown to change management in up to 74% of patients by identifying subclinical inflammation. Ultrasound is also valuable for detecting enthesitis, synovitis, and assessing power Doppler signal. Case 8. A 9-year-old girl with juvenile psoriatic arthritis presents with sausage-like swelling of her third toe. Ultrasound shows subcutaneous soft tissue thickening, flexor tendon tenosynovitis, and increased power Doppler signal at the nail bed. There is no significant interphalangeal joint synovitis. What is the primary value of ultrasound in this scenario? Option A, to confirm septic arthritis requiring drainage. Option B, to differentiate the components of dactylitis and guide treatment. Option C, to replace magnetic resonance imaging for all juvenile psoriatic arthritis monitoring. Option D, to diagnose psoriasis skin lesions. The correct answer is option B, to differentiate the components of dactylitis and guide treatment. Ultrasound is a powerful diagnostic tool for dactylitis in juvenile psoriatic arthritis. It uniquely identifies the underlying pathologies including tenosynovitis, synovitis, subcutaneous edema, and enthesitis. Studies demonstrate up to 98% sensitivity in detecting enthesitis compared to only 22% with clinical examination alone. Power Doppler vascularity indicates active inflammation. Practical advantages include that it guides local therapy such as injections, involves no radiation, is cost-effective, and monitors treatment response over time. Case 9. An 8-year-old girl has a new diagnosis of juvenile psoriatic arthritis affecting both knees and her left ankle. She has significant stiffness and difficulty walking. She also has mild elbow psoriasis. What is the most appropriate initial treatment approach? Option A, start immediately with etanercept. Option B, nonsteroidal anti-inflammatory drugs alone for 6 months. Option C, nonsteroidal anti-inflammatory drugs for symptom relief with intra-articular glucocorticoids and consider methotrexate if inadequate response. Option D, oral prednisone at high dose for 3 months. The correct answer is option C. The initial therapy follows a treat-to-target approach based on American College of Rheumatology guidelines. Start with nonsteroidal anti-inflammatory drugs for symptom relief and intra-articular glucocorticoids for active joints. Oral glucocorticoids should generally be avoided due to safety concerns. If the response is inadequate, methotrexate should be initiated rapidly as the preferred conventional synthetic disease-modifying aromatic drug. Methotrexate is usually well tolerated in children. Biologic therapy, such as etanercept, is reserved for disease-modifying aromatic drug failure or high disease activity. Etanercept is approved for juvenile psoriatic arthritis in children aged 12 and over. Case 10. A 14-year-old boy with juvenile psoriatic arthritis has persistent active disease affecting multiple joints despite 4 months of optimal methotrexate therapy. He also has significant plaque psoriasis covering 15% of his body surface area. Which biologic agent would be most appropriate to add? Option A, etanercept only. Option B, adalimumab or an interleukin-17 or interleukin-23 inhibitor given the significant skin involvement. Option C, tocilizumab as first-line biologic. Option D, continue methotrexate alone for another 6 months. The correct answer is option B, adalimumab or an interleukin-17 or interleukin-23 inhibitor. When a patient has both significant joint disease and extensive skin psoriasis, the biologic choice should target dual pathways for both joint and skin efficacy. Adalimumab is a monoclonal tumor necrosis factor inhibitor that is highly effective for both joint and skin disease. Alternatively, interleukin-17 and interleukin-23 inhibitors such as secukinumab, ustekinumab, and guselkumab show excellent efficacy for both domains. An important comorbidity consideration is inflammatory bowel disease. If inflammatory bowel disease is present, monoclonal tumor necrosis factor inhibitors like adalimumab or infliximab are preferred. These recommendations align with the 2023 European Alliance of Associations for Rheumatology guidelines. Case 11. A 5-year-old girl with juvenile psoriatic arthritis is anti-nuclear antibody positive. She has had the disease for 8 months and is on methotrexate. She has no history of uveitis and has normal vision. Based on current screening guidelines, what is the recommended ophthalmology screening interval? Option A, no screening needed as she is on methotrexate. Option B, annual screening only. Option C, screening every 3 months. Option D, screening every 6 months. The correct answer is option C, screening every 3 months for high-risk children. High-risk factors include anti-nuclear antibody positive status, age less than 7 years at onset, and disease duration less than 4 years. Children meeting these criteria must be screened every 3 months per American College of Rheumatology guidelines. Uveitis occurs in 10 to 15% of juvenile psoriatic arthritis patients and is often asymptomatic. Importantly, screening continues even when the child is on protective therapy, such as methotrexate or tumor necrosis factor inhibitors. The goal is to prevent sight-threatening complications like cataracts, glaucoma, and band keratopathy. Case 12. A 12-year-old boy with known juvenile psoriatic arthritis and enthesitis and mild psoriasis now presents with chronic abdominal pain, weight loss, and diarrhea. Inflammatory markers are elevated. Colonoscopy reveals colitis consistent with Crohn's disease. Which statement regarding the established association between juvenile psoriatic arthritis and inflammatory bowel disease is correct? Option A. Coincidental finding with no established link. Option B. Children with juvenile psoriatic arthritis have significantly increased risk of inflammatory bowel disease. Option C. Inflammatory bowel disease is primarily associated with enthesitis-related arthritis, not juvenile psoriatic arthritis. Option D. The risk is only increased in children on biologic therapy. The correct answer is option B. Children with juvenile psoriatic arthritis have a significantly increased risk of inflammatory bowel disease compared to controls. Population-based studies reveal a 9-fold increased risk of inflammatory bowel disease compared to controls, and a 3.5-fold increased risk compared to children with psoriasis alone. This association is independent of biologic therapy. Genome-wide association studies have identified shared susceptibility loci between psoriatic arthritis and inflammatory bowel disease. When both conditions coexist, monoclonal tumor necrosis factor inhibitors such as adalimumab or infliximab are the preferred therapy. Clinicians should maintain high suspicion for inflammatory bowel disease in juvenile psoriatic arthritis patients presenting with gastrointestinal symptoms. Case 13. A 13-year-old boy with known juvenile psoriatic arthritis and psoriasis is presenting with focal heel pain. On clinical examination, you find significant tenderness when palpating the posterior aspect of the heel. This clinical finding requires precise anatomical assessment. Which specific anatomical site should be assessed for enthesitis in this patient? Option A. Calcaneal attachment of the Achilles tendon and plantar fascia. Option B. Tibialis posterior tendon behind the medial malleolus. Option C. Peroneal tendons behind the lateral malleolus. Option D. All of the above. The correct answer is option D. All of the above. Systematic assessment of all inflammation sites is crucial in juvenile psoriatic arthritis. Key enthesitis sites include the Achilles tendon insertion at the calcaneus, the plantar fascia insertion, the tibialis posterior tendon at the medial malleolus, the peroneal tendons at the lateral malleolus, the patellar tendon at the tibial tuberosity, and the common extensor origin at the lateral epicondyle. Ultrasound can detect subclinical enthesitis that clinical examination misses. Enthesitis is a key linking feature to the spondyloarthritis spectrum and helps distinguish juvenile psoriatic arthritis from other forms of juvenile idiopathic arthritis. Case 14. A 6-year-old girl with juvenile psoriatic arthritis affecting 4 joints is started on appropriate therapy. Her parents ask about the long-term outlook. Which statement about disease course is most accurate? Option A. Most children will have permanent remission within 2 years. Option B. Without effective therapy, 60 to 80% will progress to extended oligoarticular or polyarticular disease. Option C. Joint damage is rare in juvenile psoriatic arthritis. Option D. The disease course is identical regardless of age at onset. The correct answer is option B. Without effective therapy, 60 to 80% of children will progress from limited oligoarticular disease involving 1 to 4 joints to extended or polyarticular disease involving 5 or more joints. The disease has a bimodal presentation pattern with a peak at 2 to 3 years showing autoimmune features and uveitis risk, and another peak at 10 to 12 years showing autoinflammatory patterns. Approximately 25% of patients experience radiological damage despite disease-modifying aromatic drug use. Progression factors include younger age under 6 years and antinuclear antibody positivity, which carry higher risk of disease progression and uveitis. Before we conclude, I would like to tell you about our Pediatric Case Review community on Patreon. This community contains all our lecture videos arranged by body system, so you can access all videos in one organized place. All presentations used in the videos are also available as high-quality photo decks, so you can read the content and practice all clinical case questions at your own pace. This is ideal for general pediatricians seeking quick clinical reference and comprehensive materials for exam preparation. For subscription details and how to subscribe, please comment below in this post, and we will message you with everything you need. To wrap up today's lecture on juvenile psoriatic arthritis, let us review the key takeaways. This is a unique pediatric entity with bimodal age distribution. Key features include dactylitis, enthesitis, and specific nail changes. Arthritis often precedes psoriasis, making early recognition crucial. The International League of Associations for Rheumatology criteria require arthritis plus either psoriasis or two of three features: dactylitis, nail pitting, or a first-degree relative with psoriasis. Treatment follows a stepwise approach from nonsteroidal anti-inflammatory drugs to disease-modifying antirheumatic drugs like methotrexate to biologics. High-risk patients need uveitis screening every 3 months. Associated conditions include inflammatory bowel disease and mental health concerns. Please follow Pediatric Case Review for more informative lectures. If you have any questions, comment below. Thank you for your attention. We hope this lecture on juvenile psoriatic arthritis has been informative and valuable for your clinical practice. The references used in this presentation are listed on this slide for your further reading. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decision-making. See you in the next lecture.